Finals SAQ60, Pulmonary Thrombo Embolism. A 54-year-old inpatient collapses in the toilet. A. What symptoms and signs might suggest an acute pulmonary thromboembolism as the cause of this acute event? Possible symptoms include sudden onset dyspnea, pleuritic chest pain, hemoptysis, syncope, anxiety and lightheadedness. Possible signs include cyanosis, pleural rub, tachypnea, wheezing, tachycardia, hypotension, refractory hypoxemia, signs of acute right ventricular dysfunction such as distended neck veins, parasternal heave, accentuated P2 and tricuspid regurgitation, cardiac arrest, swollen erythematous tender cuff. B. List the investigations and their characteristic findings that might be of further assistance in establishing the diagnosis of PTE. This includes D-dimer, very non-specific, elevated in VTE, sepsis, heart failure, and renal failure. In a setting of moderate to high pretest probability of acute PE, the ability of even a low D-dimer to exclude PE is limited. Arterial blood gas results are non-specific. Possible findings include low PaO2, low PaCO2, and increased AA gradient. Findings are variable for ECG, with poor specificity and sensitivity. ECG may help exclude alternative cause. Sinus tachycardia, non-specific ST segment and T-wave changes, signs of right ventricular strain, S1Q3T3, RBBB, atrial fibrillation and right axis deviation may be seen in PE. Chest radiograph is non-specific and non-sensitive for diagnosing PE. It may help exclude alternative diagnosis. Possible findings include focal hypovascularity, also known as Westermarck sign. Patients with pulmonary infarct may occasionally have wedge-shaped opacity that abuts the pleura, also known as Hampton hump. Pleural effusions may be seen in patients with PE. Ultrasound showing DVT in legs is supportive of the diagnosis of PE, which is positive in 45% of patients with PE. Ultrasound can be done bedside and does not require radiocontrast dye. VQ scan shows VQ mismatch in PE. Advantages: it is useful in patients whom CTPA is contraindicated, such as in renal failure or radiocontrast allergy. Normal lung scan excludes PE. High probability lung scan, 90% probability of PE is present. Disadvantages of VQ scan: high negative predictive value but frequently inconclusive. It is most reliable in patients with no underlying lung disease, which excludes most ICU patients. It is logistically difficult to organize in a patient with critical illness or an intubated patient. CTPA may show thrombus visualized in pulmonary artery in PE. Advantages: high specificity and sensitivity. Also gives information about chronicity of the clot and its consequences, such as right heart strain. It is also useful to exclude alternative diagnosis in the thoracic cavity. Disadvantages: caution in renal failure, diabetes mellitus and hypovolemia, as radiocontrast dye injected is nephrotoxic. Utility of CTPA in ICU is limited in patients with impaired renal function, inability to lie flat, in illnesses that prohibit transportation, and in patients who are allergic to radiocontrast. There is increased risk of consequences of ionizing radiation in pregnant or recently postpartum women, and sensitivity of CTPA for small subsegmental emboli is lower. The diagnostic accuracy of MRA is not as good as CT, and it is not universally available. Thrombus may be seen in pulmonary artery in PE. Echocardiography: 25% of patients with PE exhibits abnormalities of the right ventricle. Right ventricular volume and pressure overload findings includes abnormal motion of the interventricular septum, dilated right atrium and ventricle, and right ventricular hypokinesis. Sometimes thrombus can be visualized by echocardiography. The role of echocardiography includes bedside tests for patients whose condition is too unstable to be transported for further imaging procedures, useful for risk stratification, and may diagnose conditions that simulate PE, such as aortic aneurysm, myocardial infarction, and pericardial tamponade. Pulmonary angiography is the gold standard for diagnosing PE. This is reserved in cases where other diagnostic testing is not sufficient and there is high clinical suspicion of PE. It is invasive and rarely used for diagnosis. It shows absence of pulmonary blood flow in affected pulmonary artery in PE. Troponin and BNP are neither sensitive or specific to diagnosing acute PE, but assist in risk stratification. C. What are the principles of management of a shock patient resulting from massive acute PE? PE can be classified as massive, submassive, or low risk. In massive PE, hemodynamic instability is present. In submassive PE, patient is hemodynamically stable, and there is evidence of right ventricular strain or dysfunction. In low-risk PE, there is no evidence of shock or right ventricular strain. Massive PE is a medical emergency. I will call for help, assess and manage the patient, adopting an ABC approach. Resuscitation involves providing 100% oxygen. Intubation is likely to be required. Obtain IV access, cautious IV fluids and inotropic support, depending on patient condition. Prepare for cardiac arrest, call for drugs and defibrillator. Likely rhythm would be PEA. Resuscitation efforts is expected to be prolonged once thrombolysis is given. Definitive treatment of massive PE should not be delayed and is based on clinical findings and, if possible, bedside echo. Goal of therapy is to reverse the obstructive shock caused by acute right ventricular failure. Thrombolysis with alteplase. This is indicated in massive and perhaps submassive PE. It improves hemodynamics. If successful, thrombolysis can reverse obstructive shock. However, no survival benefit has been proven. Assess for contraindications of thrombolysis, but risk-benefit analysis in arrest or peri-arrest situations favors thrombolysis. Standard thrombolytic regimen is alteplase 100 mg infused over 2 hours. Major hemorrhage may occur in 10 to 12%, up to 6% develop intracranial hemorrhage after thrombolysis. Unfractionated heparin infusion to follow thrombolysis. Clot dissolution by thrombolysis releases thrombin, thus IVI unfractionated heparin prevents thrombotic reocclusion. Targeting PTT ratio of 1.5 to 2.3. Invasive techniques should be considered in centers where expertise and facilities are available. Survival rates of 83% have been reported with emergency embolectomy. IVC filter is indicated in acute PE despite therapeutic anticoagulation. Evidence of VTE with an absolute contraindication to anticoagulation. Proximal DVT in legs with free floating thrombus or with limited cardiopulmonary reserve. IVC filter may reduce the risk of recurrent PE in the first 7 days by 4%, but does not change the rate of recurrence long-term and may cause additional complications without anticoagulation, such as subsequent DVT and IVC thrombosis. Thus, resumption of anticoagulants is recommended when bleeding risk decreases and to remove the filter when safely indicated. Novel anticoagulants such as rivaroxaban and episaban are now first-line therapy for the treatment of VTE once the patient is stable, rather than warfarin. Additional information. What are some risk factors for VTE? Risk factors of VTE may be classified as causes of venous stasis, thrombophilia, and endothelial injury. Venous stasis may occur with prolonged bed rest, prolonged air travel, and heart failure. Thrombophilia occurs in malignancy, heparin-induced thrombocytopenia, antiphospholipid antibodies, nephrotic syndrome, inflammatory bowel disease, pregnancy, hormone replacement therapy, oral contraceptives, and specific chemotherapy agents. Endothelial injury may occur in major surgery, trauma, and previous venous thrombosis. Common risk factors for ICU patients includes major surgery, major trauma, acute medical illness, and ICU-related risks such as prolonged mechanical ventilation, CVL, vasopressors, drug-induced paralysis, and prolonged immobility. What thromboprophylactic regimens should be prescribed for various conditions that increases the risk of VTE? Low-dose unfractionated heparin and low molecular weight heparin can be considered for acute medical illness, major abdominal surgery, thoracic surgery, cardiac surgery with complications, hip or knee surgery, major trauma, head or spinal cord injury. When there are no contraindications, Intermittent pneumatic compression of lower limbs is indicated in patients whom anticoagulants are contraindicated and should be applied for patients who underwent major abdominal surgery, thoracic surgery, cardiac surgery, craniotomy, major trauma, head or spinal cord injury, and in patients with active bleeding or high risk of bleeding. What are the sources of pulmonary embolism? This includes thrombus of deep veins of the leg, such as iliac, femoral, and popliteal veins, central venous lines, pelvic veins, such as after gynae surgery or difficult labor, fat particles, amniotic fluid, air bubbles, and foreign bodies, such as talc or cotton fibers in IVDU patients. How common is VTE in critically ill patients? VTE is underdiagnosed. Literature has reported 33% in medical patients, 18% in trauma patients, and 27% in respiratory patients. What is the recommended algorithm for the diagnosis of pulmonary embolism in the ICU for a patient who is hemodynamically stable? Clinical findings, including lab and ECG results, are neither sensitive nor specific for the diagnosis of PE. CT chest angiography or VQ scan is necessary to confirm the diagnosis. In hemodynamically stable patients in whom PE is suspected, initial diagnostic tests should be CTPA. VQ scan should be considered if CTPA is contraindicated. If these tests are non-diagnostic, a Doppler ultrasound scan of the legs and echocardiogram should be performed. If the diagnosis is still not confirmed and clinical suspicion of PE is high, pulmonary angiography may be performed. What is the recommended algorithm for diagnosing PE in patients who are hemodynamically unstable? Anticoagulation should be started as soon as PE is suspected if it is not contraindicated. Because moving an unstable patient is difficult and potentially unsafe, initial tests should be Doppler ultrasound scan of the legs and echocardiography to look for signs of right ventricular dilation or dysfunction. Occasionally, clot can be seen in transit in the right ventricle. If patient anatomy allows, the main, left, and right pulmonary arteries can be imaged with echocardiography to evaluate for clot. A portable chest radiograph should be obtained to evaluate for alternative diagnosis. Evidence of DVT with new right ventricular dysfunction on echocardiogram without any other alternative diagnosis is often sufficient to make a presumed diagnosis of PE. What are the goals of treatment for submassive or low-risk pulmonary embolism and how are they achieved? Major goals of submassive and low-risk PE therapy are to prevent further thrombotic and embolic complications and to promote resolution of existing thrombosis. In the short term, unfractionated or low molecular weight heparin should be administered. Oral anticoagulation therapy can be started when the patient's condition is stable and no invasive procedures are planned. The role for systemic thrombolytic therapy or catheter direct thrombolysis is still debated and without clear guidelines in the literature. When should low molecular weight heparin be used? Low molecular weight heparin is preferred to warfarin or novel oral anticoagulation agents in the setting of active malignancy. Are there important long-term sequelae of pulmonary embolism? Pulmonary hypertension occurs in approximately 4% of patients within 2 years after their first episode of PE, which is called chronic thromboembolic pulmonary hypertension. It is unknown if thrombolytic therapy reduces the risk of pulmonary hypertension development. Patients suspecting to have pulmonary hypertension should be evaluated with VQ scan, CTA chest, right heart catheterization with pulmonary angiogram. Surgical thromboembolectomy remains the first-line therapy. Riociguat is a pharmacologic therapy approved by the US for treatment of chronic thromboembolic pulmonary hypertension and is often used in patients without surgical options. This drug sensitizes soluble guanylate cyclase to endogenous nitric oxide, and it directly stimulates SGC receptors independent of nitric oxide availability, resulting in vasodilation and anti-proliferative effects. Thank you.